What happens when endometriosis doesn't just affect the pelvis, but the gut, the nerves, and the very way the body communicates with itself? Today's episode brings together two specialties who don't often sit at the same table, a neurogastroenterologist and a colorectal surgeon, to unravel why so many patients fall through the cracks. From bowel endometriosis to mast cell activation, from lingering post-op symptoms to the role of multidisciplinary care, this conversation gets real about the complexity of endo and why answers aren't always straightforward. If you've ever wondered why symptoms persist even after surgery, or why your GI and pelvic pain seem inseparable, you're going to want to lean in for this one. Let's get started. Welcome to Endo Battery, where I share my journey with endometriosis and chronic illness while learning and growing along the way. This podcast is not a substitute for medical advice, but a supportive space to provide community and valuable information so you never have to face this journey alone. We embrace a range of perspectives that may not always align with our own, believing that open dialogue helps us grow and gain new tools. Join me as I share stories of strength, resilience, and hope, from personal experiences to expert insights. I'm your host, Alana, and this is Endo Battery, charging our lives when endometriosis drains us. Welcome back to Endo Battery. Grab your cup of coffee or your cup of tea and join me at the table. Today, I'm honored to welcome two incredible physicians to the table, both whom bring unique expertise and deep commitment to caring for patients with complex conditions. First, we have Dr. Zach Spiritos, a neurogastroenterologist and internist whose journey took him from Philadelphia to North Carolina, where he's now rooted with his family. Dr. Spiritos trained at UNC School of Medicine, completed his residency at internal medicine at Emory University, and went on to a fellowship in gastroenterology at Duke. He specializes in a wide range of gastrointestinal and liver disorders, with particular interest in irritable bowel syndrome, functional abdominal pain, motility disorders, and dysautonomia, including conditions like POTS and mast cell activation syndrome. He also has expertise in GI complications connected to hypermobility syndromes like Ehlers-Danlos. What sets Dr. Spiritos apart is his holistic approach, weaving together nutrition, lifestyle, and gut-brain therapies to empower his patients. Also joining us today is Dr. Vincent Obias, a professor of surgery and chief of the Division of Colorectal Surgery for the National Capital Region. Dr. Obias trained at the Medical College of Virginia, Eastern Virginia Medical School, and Cleveland Clinic, with additional advanced training in laparoscopic colorectal surgery at University Hospital's Case Medical Center. He is double board certified in general and colorectal surgery, and his specialties include robotic minimally invasive techniques, as well as surgery for deep infiltrating endometriosis. Beginning October 2025, Dr. Obias will be joining Dr. Melissa McHale and Vicky Vargas as a partner at Washington Endometriosis and Complex Surgery Group. His research and clinical work have made a lasting impact, particularly in robotic surgery outcomes and complex endometriosis care. Together, these two doctors bring insights from both the gastrointestinal and surgical perspectives, making today's conversation one that promises to be both informative and empowering for patients and providers alike. Please help me in welcoming Dr. Zach Spiritos and Dr. Vincent Obias to the table. Thank you both so much for joining me today, sitting down at the table for this conversation that's a little nuanced in direction, as that you guys don't typically work hand in hand together, but often symptoms go hand in hand. Somehow, endo patients are working through the neurogastroenterology as well as colorectal side, trying to figure out the different pieces. So thank you both so much for sitting down and doing this with me.
Oh, yeah. Thanks for having us.
Thank you very much.
Can you give us each a background, and we'll start with you, Vince, a little background on what you do and kind of what you specialize in so that we have a good place to start?
Sure. I'm a colorectal surgeon, board certified, about 20 years of practice. I take care of deep infiltrating endometriosis, colon cancer, rectal cancer, diverticulitis, inflammatory bowel disease. I've been doing endometriosis surgery with my minimally invasive gynecologic colleagues, both at GW and Hopkins, and it's a passion of mine. There's a lot of surgeons who take care of cancer, being one of them, but there are very few that take care of endometriosis, and I'm starting to specialize in it, and it's incredible. Some of the most challenging cases are women with endometriosis, and certainly it's a population that can really, benefit from someone who has a lot of experience in pelvic surgery. So I'm very, very excited about it.
Yeah. Zach, we've had you on before, but you're back again.
I'm a neurogastroenterologist. So I trained at Duke, and then I was at UNC, and then branched out to do my own practice. I work with folks that not only have issues with the tube itself of the GI tract, namely the esophagus to the rectum, but also the wiring between the tube and the central nervous system, specifically how the tube is perceived and felt, and also how it moves and propagates kind of food, debris towards our rectum. And try to help people work through this space as well.
Yeah. And I think I didn't put these pieces together very well prior to us kind of talking about this, but there were so many questions last time that Zach and I did a podcast together that I felt like I couldn't answer these questions, and they were pretty prevalent. Like a lot of people were asking these questions. And so just jumping into this, I really want to get a better idea of how it all functions in your own specialties, if you will. Can you describe the role of bowel endometriosis care? Like when you see, Vince, when you see bowel endometriosis, what is the approach to that pre-surgical approach of mapping that out?
So I always do this with gynecology. I don't feel that endometriosis is purely a colorectal issue. The gynecologists and my colleagues like Dr. Vicky Vargas and Melissa McHale, this is what they specialize in. So I usually get them involved. Even when some patients come in with pelvic pain and a CT showing a mass as endo, I still get them involved, a gynecologist involved. Generally, women present with pelvic pain, rectal bleeding at times, and that can be a very broad area when dealing with these symptoms. And so the workup is very broad. Sometimes the pain and bleeding that they're having is not endometriosis. So when I see them, we talk about, the workup for this, which can be a variety of things, including colonoscopies, rectal exams, of course, a complete history and physical. But when I see them and they're involved, they're generally about 30 to 40% of women with endometriosis. It will involve the rectum or the bowel of some type. So it's important to have, bowel surgeons like myself involved at the start.
Yeah. How does it affect the gut mechanically, though?
So obviously, if it gets large enough, you can have obstructive type symptoms. You can also, if it's deep infiltrating and eating through the wall full thickness, you could see bleeding, and you'll see bleeding per rectum during your menses. It can also, the rectum is sort of it's a capacity. Its job is to sort of stretch and maintain stool. So when you go to the bathroom, you can make it. And if you have endo there that kind of restricts it from inflammation, these patients tend to have a bit more urgency. Well, like they'll go to the bathroom and they don't see much. So they'll have some interesting symptoms like that. Some of these patients will be, because of what I've discussed, will have chronic constipation. And that workup, it can be pretty advanced and broad. But endo is, it's almost one of those disease processes that we're taught in school, that it's almost like you do a full workup, and if you don't find anything, then it could be endometriosis. And it's terrible. We have much better ways of finding these nodules now than we had in the past, but that's only been in the last 10 years that I've seen. But yeah.
Zach, on your side of it, how does the gut neurologically work typically with endometriosis patients that you see, and the difference between that, what Vince is saying, and what you see?
I think it varies. It's definitely pain predominant. And so, these patients are labeled with IBS, whatever that means, where they have a lot of pain and alterations in their bowel habits with a diagnostic workup that is fairly unrevealing. So that's what's really important to talk to these people. And, because if you stay in your siloed world of GI and you say, oh, what's your Bristol stool scale? Like, how many times are you going? Do you have urgency? Like, you're also like, do you have your period? Is it heavy? Is it painful? Do you have pelvic discomfort? Right. And if you expand the conversation to a true review of systems, which sometimes because of the limited time that you have in clinic, or you're just kind of so focused on the GI world that you sometimes miss that. But endometriosis, can certainly cause, I typically just think pain. Can it certainly cause diarrhea? Sure. Or alterations in bowel movements. As Vincent said, if you have this huge kind of endometrioma, you can have obstructive symptoms. I personally haven't seen that a ton, but he obviously in the surgical side sees that a lot more than I do. Alterations in bowel habits, pain, but so many things can do that, right? So many things can do that. And so I think it just behooves you to just kind of talk to the person and just make sure see if there's any kind of gynecologic symptoms as well that would kind of lead you towards endometriosis. And my teaching is, if you have painful periods, it's endometriosis until proven otherwise. Like, it's your job to prove that it's not that.
Yeah. I love that approach because I think that should be taught in school across the board because it affects so many different systems that until proven otherwise, especially if it's cyclical, should be thought of as endometriosis. Now, I think what's interesting, Zach, you talked about your mast, and this was earlier, your mast cell activation patients. All of them have endometriosis.
All of them. I mean, not all of them. A lot of them do. It's just
most of them.
Really high rate. Yeah. So I see a lot of patients who have hypermobility, and some have POTS or dysautonomia, and they a lot of these times have mast cell activation syndrome. And so when we talk about everything that's going on, and everybody, when in a typical visit, and someone who doesn't have mast cell, they go to their PCP and they're like, "Is anything going on today?" And mast cell, it's like, "What are the 5 top things that bother you today?" Right? Mm-hmm. And because they have so much going on, they have endless amounts of symptoms. And that's why these visits are required to be really, really long. And when you start kind of going down the review of systems, like, do you have painful, heavy periods? The answer is often yes. And so you often see heavy periods. Mast cells secrete a lot of different chemical mediators. Heparin is actually one of them. You actually see elevated heparin levels in their blood. And so they tend to have heavier periods. And that's fine. You can certainly ascribe a lot of things to mast cell activation syndrome, but the rate of which we see endometriosis is so high that I have a low threshold to involve gynecology or, colorectal surgery to evaluate these patients right off the bat.
Yeah. And part of the challenge there too, for a lot of us, is figuring out, okay, is it endometriosis, or is it these other things like mast cell or, POTS playing a part into this? One of the things that I think a lot of people struggle with is they have lingering symptoms post-operatively. So they've had excision surgery and they have lingering symptoms, whether that's constipation, whether that's food sensitivity. It might be, who knows? Like, there's just a lot of bloating is another one of those things. Vince, when you're doing surgery and the outcome of that, and they're still having this bloating, they're still having, all of those things, is it concern for you if there's nerve involvement that is causing this? And this kind of plays hand in hand probably with what you do, Zach, as far as like the nerve involvement as well.
Yeah. So I will say that those symptoms are common after bowel surgery. So when let's say someone has diverticulitis or colon cancer or rectal cancer, whenever we cut the bowel and put the 2 ends back together, bloating, discomfort, constipation, diarrhea, those are common symptoms to have after surgery for about 2 to 3 months, up to 6 months. Now, I will say after 6 months after a colectomy, the symptoms that you have are sort of your new pattern. So I tell patients all the time, I'm like, not sure you're going to have a bowel movement like you had in your 20s, but after 6 months, you'll be predictable. And those conversations are really important to have. And since I'm a colorectal surgeon that do bowel surgery, I do have them for patients. So their expectations are like, "Yeah, doc, I'm bloated, or a little bit of gas, or I have urgency and nothing much is coming out, or I have like 5 or 6 BMs a day," but they're not upset because they knew about it coming in. Meanwhile, honestly, gynecologists, they don't do a lot of bowel surgery, but if you're shaving or doing anything on the bowel or pelvic surgery, you could still have these same post-op symptoms. So that kind of education is important to have up front so that they understand that's part of the healing process. Now, certainly, can endo come back quickly? Certainly. I think that's one of the things we worry about. But when we do excisional, they don't usually come back that quickly. But you are dealing with the post-surgical in terms of scar tissue, in terms of inflammation from the surgery. Like I said, that if you're doing pelvic surgery and you're mobilizing everything down there, even if you don't cut the rectum or bowel, the scar tissue and inflammation will change your bowel habits afterwards. And so when you go in with bloating and discomfort and you leave with bloating, you're feeling, oh, nothing was done. But that's part of the process. Give it time. 3 to 6 months later, that should be improved and certainly more predictable. In terms of nerves, so the nerves I deal with, especially in cancer, which we don't really run to we run into in endometriosis, is sort of near it's associated with like sexual function, in men, erection, obviously clitoral erection, it can be associated with, and bladder function. But they're more posterior to the rectum and maybe not necessarily intrinsic to the bowel. But that's normally the nerves that we would deal with. And that's more of removing the rectum for cancer.
Yeah. Zach, do you see after surgeries, if people come to you, they're still having issues with GI, it could be related to that mast cell activation post-surgical that's ramped up even more because of surgery, you think?
It depends. Like Vince said, like, you don't want to pathologize everything post-operatively, right? Like sometimes it's just a healing process. The question is like, does it make sense, right? Like, did they remove the TI, the terminal ileum, and now acid mouth diarrhea? Like that makes sense to me, right? If you have a colectomy and you have diarrhea, like, all right, like you lost your rectum. If there's rectal sparing surgeries and whatnot, but does a surgery and what happened pair with what you're experiencing, right? You can develop certainly like SIBO post-operatively, right? Is it adhesions? Is it the narcotics that take post-operatively? Is it, so there's things that exist certainly outside of mast cell activation syndrome. So you take the person, the surgical intervention, and what their symptoms are, and you try to combine all three. I have had patients with mast cell whose symptoms were attributed to endometriosis. They had endometriosis, surgery was performed, and they felt no better because it was just mast cell, right? But you have to do that. You are required to look for those things because endometriosis can affect so many things, fertility, right? And so you want to do your due diligence when there's something you can intervene and fix. And you can easily fall into a trap where you blame everything on mast cell activation syndrome, which you don't want to do. You want to, fortunately when people come to me, they've had all the testing. So I don't really have a lot of to run left, but you still want to keep a wide kind of lens. Don't be myopic and keep everything in perspective. And so, yeah, do the symptoms fit what happened? And can you kind of create a nice story with what's happening if you can? And, there's food intolerances and brain fog after surgery. Like that's not related to the surgery, right? That's something different. And so you just have to understand the surgery, understand what the symptoms are, and how to kind of connect the dots.
Yeah. And I can tell you, having a good surgery with a qualified expert in this will make a difference in the outcomes. I mean, if you're having a general GYN, and I'm not bashing on them, but if you have a general GYN doing your surgery, chances are there's disease left behind. And that because they're not trained to excise the disease. They're trained oftentimes to do ablation, which can cause more scarring and stuff like that. Vince, have you experienced that? You've done resections and you've been in surgeries where they've had multiple surgeries. They continue having these symptoms. Is it typically disease state that you're seeing again, or is it, something else completely?
Yeah, I will say that every time I'm in a case, especially now working with Dr. Vargas and Dr. McHale, their success rates in finding nodules and involvement of the bowel is like 100%. So whenever, and like we had mentioned and discussed earlier, sadly, most of the surgeries I'm involved, there's been previous surgery, it's just sad to see. Oh, honestly, the gynecologist did the right thing. Rather than tackle this complex nodule on the rectum and have a complication that's just terrible, don't do anything, document it, get it to an expert. But yeah, I mean, when they're having post-surgical, and there's usually because of endometriosis that's been left behind, sometimes inadvertently and regrown, and sometimes they knew it and they're like, look, I'm not gonna risk it. And it's the smart thing to do, understanding that, they're a little bit out of their element. The patient is not aware a big surgery can happen. And it's better to just, get out, let them recover quickly. But it's very frustrating, honestly, for the patients who are like, they came in, they're hoping to have one procedure, they're hoping to have this done, taken care of, and they've been told not only that, we're doing this, but there's going to be, we couldn't do it all, but there's also a worse situation and you may need even more advanced, extensive stuff. So yes, I absolutely have seen that. And the majority of the time it's because of there's endometriosis being there.
Okay. Yeah. I think that's probably pretty common with people that I hear, including my own story of disease being left behind. But that goes to say that that's why this education is so important, right? And we have to keep educating about this. Zach, is there a ideal pre and post operative routine or things that we can do to help support us pre and post operatively when it comes to GI related things?
It's a really good question. I would probably, I don't know if I'm the right person to answer that question necessarily. I think you just want to do your due diligence and make sure that no other pathologies at play. But I don't know if there's anything from a GI perspective specifically that you would dial up to ensure better outcomes. Like I think I'd leave that to the surgeons and the gynecologist to make sure the patient's like the right candidate and surgical candidate. And it's probably not my job to decide. Certain things we can do to optimize people from a mast cell perspective.
That from the mast cell part of it, because I know a lot of people, including myself coming out of it, things flare really bad. How do we help alleviate a little bit of that pre and post operatively?
Yes, we want to make sure their mast cell is under as best control as possible preoperatively. I tend to reach out to the surgeon to discuss the case and just say, hey, this is how I would think about this specific patient, whether they're hypermobile and they need a neck brace during a surgery because they have a lot of craniocervical instability. Yeah. Do they have POTS and just need do they really need to be fluid resuscitated before the case and really just make sure that they're adequately hydrated? If they have mast cell activation syndrome, there's certain anesthetics that tend to flare mast cells and postoperative narcotics like morphine that tend to be more aggravating for mast cells. And there's also a dialogue like what happens if they have a huge flare and go into anaphylactic shock? Like we should probably have like steroids and, H1 and H2 blockers ready to go in case that happens. And so I have a protocol that, I've written with I haven't written, but I've adopted from other, mast cell clinicians. And I often will reach out to the surgical team and say, this is kind of what I would do, and how I would approach this patient kind of perioperatively and intraoperatively just to get the best outcomes.
Yeah.
Yeah. Honestly, like the way Zach pointed out, it's important to emphasize that when you're dealing with something like endometriosis that can affect so many different areas, colon, rectum, diaphragm, bowel, bladder, it's multidisciplinary. Just like when I deal with rectal cancer, we have radiologists, oncologists, radiation oncologists. We have a variety of people on the team to discuss it. And so endometriosis, especially complex stuff, is starting to lean that way, where you have multidisciplinary teams talking about it so that we don't miss things. Zach pointed out.
Yeah, for sure. And I think too, it's important that we recognize that it takes multiple people outside of just one specialty, meaning just endometriosis. It's like pelvic floor, acupuncture. There's different ways that we can support our bodies walking through this. And if we all talk together and have that true team, outcomes are so much better. And that's proven. Like that is a proven thing where if you have a good team, solid team going into surgery, more prepared, outcomes tend to be a little bit better for you. So that was one of the things I learned the hard way as well.
Sadly. Yeah.
Relax postoperatively.
You what? Relax?
Postoperatively. Got to keep the bowels moving.
Yep.
Relax.
And
yeah.
gum,
I
right?
love that stuff too.
Chewing gum?
Yeah.
Oh, yeah.
So chewing gum is used for return of bowel function right after surgery. Yeah. So you can chew gum, and so you end up swallowing a bunch of air. So there's been studies on that. But but that's right after surgery. I mean, I don't recommend chewing gum for the next 6 months, but if you want to, that's fine.
I'll make it bloated all right. Do you have randomized people to different like bubble yum versus like big chew?
Well, when I was a resident, I actually I gave everybody a pedometer, and I had them walk around over at Case Western, and I was able to demonstrate the more steps you did, the faster you had flatus and we're at home. So, I have looked at some of that stuff, and steps is one of them for sure.
That's very clear.
For sure. Zach, is there a way to retain bowel and brain communication after a major bowel surgery? I think this is something that many of us struggle with, is that we get in patterns and that it becomes this challenge of like, this is what my body's always done. And now I'm still in this battle of, is it really going on still? Or is this just the way my body is trained? I hate the word psychosomatic, but a lot of times that's what they refer to it as. Is there ways that we can retrain our brains and our bowels to work better after surgery?
That's a really good question. I think it's, you have to take everything. It's such a bailout answer, but you got to take everything on a case by case basis. So if someone has been like, what are they experiencing post-operatively? Is it the same diarrhea they've always been that's kept them locked up in the house? And is that stress about having diarrhea making the diarrhea worse to where you're anticipating like, oh my gosh, like if I go out, I just know I'm going to have diarrhea as soon as after the appetizers. And like that, you think it into existence, right? And so you kind of have to untangle like, okay, so like what has your history been? What are you currently worried about? What is actually happening? And what are how can we intervene and help things out? Like, are you ragingly constipated? Like, why are you constipated? Is it a pelvic floor issue, right? Is it because there's not enough fiber? Is it because you're in fight or flight mode and you're really stressed? Is it because you have a dysautonomia and you have POTS and it's because your colon doesn't move? And then it's like, okay, well, let's do what we can from a dietary perspective and a pharmacotherapy perspective to maybe help alleviate the bowels to some degree, but there's always a chance that the brain will override everything we do and be like, like we're going to back things up or we're going to get things going, right? And so how do we address that as well? So if we unentangle things and we say, okay, well, there's a really disruptive thought pattern that is making your bowels really bad, right? So that anticipatory anxiety, or man, if I don't poop like by 8 a.m. this morning, the rest of my day is ruined because I'm going to get bloated. It's going to be uncomfortable and everybody's going to notice and it's going to be terrible. And that just makes the symptoms that much worse. And if we realize that thought pattern is happening, which in turn will make the bowels worse, then maybe we talk about like, maybe talking to a therapist, like a GI therapist, like is a hypnosis something that we can utilize? Is cognitive behavioral therapy something that we can use? So it really is like take it on a case by case basis, but what buttons can you press? Right. Medications, diet, exercise, sleep is a humongous one. Lack of sleep definitely predicts next day GI pain. And so it's just, you got to just kind of look at everything and see how they play off each other and just listen to the patient, right? Just listen to them and see like, where can we meet in the middle here and find solutions to what may be going on.
Yeah. I'm going to do something that is probably a little unorthodox. And I got so many messages, like I said before, which is why we're coming together for this. So I want to read you guys something and I want to get both of your perspectives on this because I think this will help clarify maybe some of the questions that I got previously and put it in a way that is maybe helpful. And this is not case specific. It is not a medical advice. This is just insight into this. So sample message. I'm a mom of a 21-year-old daughter who has non-cyclical GI symptoms since she was 13. 2 years ago, she was diagnosed with endometriosis after excision surgery with removal. She didn't have improvement after surgery, and 2 years later, she still struggles with ongoing nausea and frequent diarrhea each day. She takes SSRI and was on oral contraceptives, but isn't any longer. She has been treated for SIBO, received pelvic floor PT and functional medicine protocol, tried low FODMAP and elimination diets. She had 2 unremarkable colonoscopies and endoscopy. Zach, you can fill that in. Endoscopies. And yet the GI symptoms are still there. She has also had a motility study that was also within normal limits. Any ideas that you would have for helping with symptoms or overall treatment?
Before? Just kidding. GI doctor will probably say good things. Have you tried a PPI? I don't know. That's really complex. So when I see a patient, right, I have 200 pages of the records. They've been everywhere. They've had all the testing. And I say, I don't care what their tests say. Like, sure, there are some tests that are helpful. I want to hear your story and how you got here. What makes it better? What makes it worse? What medication's worse? What medications have helped? So you can understand like the mechanism of action of that. And so, yeah, I mean, there's so many different, like does she have brain fog, fatigue, migraines, flushing, allergies that would make you think this is mast cell? Does she have some form of dysautonomia? Does she have visceral hypersensitivity? Did this all happen after like a huge GI bug? So I think you just have to listen to the person. There's not a one size fit all approach. There's not a one medication. Like I don't have a box back here of like, oh, I have this golden pill that she's never tried before. Like maybe we bust that out. Like you really just have to listen to someone and see how they got here. So I always tell everybody, tell me how you got here. When's the last time you felt great and what's happened since then and what has worked and what hasn't worked. And if there's like if there was a test that was positive that showed why everything was wrong, like you wouldn't be here, right? And so you can run all the tests. We have so many amazing tests, okay? The thing is that we have blunt edge tools for very elegant pathophysiology. And so when you have you have dysmotility of your bowels. Well, there's like 3 things we can do for that. Like we don't have a lot of medications for that. So you just have to kind of listen to somebody, get a sense of what's going on. Is it stress induced? Is it more pain? Is it nausea? Nausea, we scope nausea all the time. It drives me nuts. Nausea comes from the brain. Okay. Like if you have postprandial nausea, but around the clock nausea is a brain process. Okay. And so why is that there? Is it stress? Is it mast cell? Is it a medication? Is it an infection? You just have to kind of go through everything, deconstruct everything, and then build it back up to where you can convince, like a narrative has to fit, right? You don't take any symptom in a vacuum, be like, oh, nausea. Like, why is that there? Like, how did they get there? Did it happen post-operatively? Did it happen after a breakup? Like, what's happening here? And so you can't take a symptom and be like, how do you treat this? It's like, well, it's in the context of who that person is. You don't treat nausea. You treat Bill's nausea or Susan's nausea. And there's a story there that you have to untangle. And then once you get there, you can push the right buttons.
Right.
That's my.
I love it. Vince, when you hear something like this, what is your automatic response to that? What are you hearing this that you would look at maybe from a different lens?
Well, I mean, as a surgical side, I would probably say surgery may not be the answer. I mean, this is such a broad situation that it's not going to be like a magic pill. As Zach mentioned, well, I don't have a magic blade to say, let me just cut out this section of the bowel. Let me cut out a couple of stitches here. You can certainly try to rule out endometriosis. MRIs of the pelvis are being done now. You can do MR enterography to take a look at her GI tract, which we definitely use in inflammatory bowel disease, but we can certainly use for her if she has GI symptoms and you're looking to see if there's any kind of inflammation of the bowel or small bowels abnormal. One of the newer techniques that Vicky Vargas and Melissa McHale have sort of pioneered is transvaginal ultrasound to look at pelvic nodules and look at nodules in the rectum to see if there's anything there. But the symptoms that are being described is very broad and nonspecific. And you have to be really careful before saying, let's get the surgeon involved, because I mean, sad to say, we're like a hammer. Our answer is going to be sometimes surgery, which I don't think in her case it makes a lot of sense. You got to sort of think outside the box and visualize the situation. Make sure that, what's being done for her is going to be something that will be definitive rather than something frustrated. It may come down to something like a laparoscopy to look internally to make sure we're not missing something. But boy, I think there's a lot of things that we can done beforehand before it gets to that step.
Yeah. How much pain, how much of this is neuropathic and how much is it inflammatory? Because I think that also could be, I mean, maybe they coincide. I don't know. But I think there's probably some play in there for both of those.
Well, certainly you can definitely get studies to look for inflammation that would be anatomically and physiologically an issue, like say like an MRI enterography or MRIs or scans and whatnot. And certainly in someone in her age, you would definitely lean towards MRIs so it's, the cumulative effects of radiation and CT scans is not great. And you can find those. And certainly there are blood tests that we can do to look at inflammatory factors. But if there's subtle inflammation, sometimes you have to do endoscopy and colonoscopy, take a look at the mucosa directly to see. It's a frustrating scenario. And it may be more, as Zach had mentioned, it may be more not associated necessarily with something physical. It could be something else associated with her symptoms that a multimodal team or a therapist or whatnot, or figure out if it's stress-induced or environmental in some way. Because I think you're going to have to think out of the box, because she's had so much medical stuff thrown at her already and surgical stuff that doesn't seem to be addressing it.
There's no test that's going to pick up what's going on.
Yeah. I was waiting for you to say
magical test that's going to pick this up. And to tease out neuropathic versus inflammatory pain, are we sure that's not one and the same?
Right.
Right? Yeah. Like, I mean, the immune system and the neurologic system and the hormonal system are intimately linked, right? Yeah. So I don't think you can tease one out and be like, oh, it's neuropathic, put her on gabapentin. Like, that's not going to work. Right.
Yeah.
I think you have to understand why this is like, why isn't the test picking up on it? Like, why is this we have very elegant tests. Is it a brain gut communication issue? Is it a central process? Or is it something like mast cell activation syndrome, where it's just, there are very pervasive symptoms, but there's shortcomings in the testing that we can use to pick it up.
Yeah. Well, and I think that not very many people are going to think mast cell activation. In fact, I've had doctors roll their eyes at me.
People don't think it exists, for sure. Yeah. I will say that I have hundreds of people in clinic that all have mast cell activation that would disagree. And we didn't learn anything about it. Like, I was at Duke not too long ago. I didn't hear a darn thing about it until a couple of years ago. And I had about 40 people in my clinic that I had no idea what to do with. They had all these bowel symptoms, but they also had migraines and endometriosis and allergies and flushing and tachycardia. And they were 24 and had 7 subspecialists. And they're being treated for migraines, inappropriate sinus tachycardia, endometriosis, IBS. And you're like, there's got to be something here, right, guys? Like, what's the statistical likelihood that they have independently all of these symptoms? It's not. They have mast cell activation. And you did a little digging, and it's like, and you put them on. I remember my first patient and they thought had Crohn's disease. They put her empirically on Skyrizi for small bowel Crohn's disease, because they thought they saw a wisp of some inflammation on a video capsule study. And she had bloating and fatigue and migraines and heavy painful periods. And we put her on Pepcid and Zyrtec, and almost all of her symptoms went away. It doesn't always go like that. It doesn't for the most part, but you put someone on some histamine blockers and they feel phenomenal. And I would say that 9 out of 10 of my patients don't respond that way to that. But I remember seeing that. I was like, oh, there's a lot about this world of medicine that I don't get. And I spent a ton of time in the hospital and reading. And there's just, the more I read and learn more, the more I don't understand. I think there's we reduce people's symptoms down to MRIs and CT scans and x-rays and blood work. It's like, look, there's a world beyond this that we don't understand to properly categorize pain and inflammation and brain gut communication and mast cell activation. And it's really tough. And these patients get minimized and gaslit a lot because we didn't learn about any of this stuff.
Right. Well, and there's also that link too with May-Thurner Nutcracker syndrome. Like these all play a part in that as well. And that's a whole nother topic with someone like Dr. Brooke Spencer. But there's similar symptoms for a lot of these people as well. So that's
like downloads, the connectivity. So, mast cell activation primarily happens to bendy people. And they also, their connective tissue doesn't work very well. Everything sags. They get pelvic venous congestion and they get median arcuate ligament syndrome, which I thought never, ever, ever happened. I see it once a week now. Okay. I see SMA syndrome every 2 weeks. I see nutcracker and pelvic venous congestion on a weekly basis. That's because I really see a ton of people with hypermobility. And this patient population doesn't play by any rules that we have. You can write a whole different medical textbook on these people. And when they go to the traditional hospitals and clinics, they just don't know what to do with them because they don't fit in any box. So they say, maybe it's anxiety, maybe it's stress. And it's really frustrating. And when I get on the phone and call the inpatient hospital team, like, hey, this is what's going on, I get looked at like I'm a nut. And I was like, well, tell me what's going on then. Like, do you have another explanation for what's happening? And so it's just, I do think that mast cell is on the rise in prevalence. And I think COVID is unleashing a lot of this. Like, we haven't had anything new in medicine since HIV, right? And mast cell is just this new thing. The thing is, mast cell's invisible. Like HIV and AIDS, you can follow CD4 counts, like something real was happening. There is like this boom of these patients. They're everywhere. And if it's like the one in medical practice, Vince, if you saw like, oh, that person is allergic to 35 medications, they must be off the rocker. It's like, no, their mast cells hate every medication. They're exquisitely sensitive to all these medications. And we see them all the time. We just don't know what to do with them. And I really think that COVID really increased the prevalence of mast cell. And I think in 10 years, we're going to start to appreciate and understand this a lot more than we do now, because we have a very faulty understanding of what's going on.
Well, and if you want to know my theory on this too, and you guys can sound off before we wrap up, but one of my theories is because when you have a hypermobile person and that connective tissue is so much looser, I don't know about you, but for me, my thought process is like, if that's looser, you're giving way for a lot more things to happen within that tissue as it stands. Like there's, with the endometriosis specifically, with, cells implanting, when you have a connective tissue that's already loose, it's giving room for that to implant more. I don't know. I'm not the scientist.
I have like 7 different theories, right? So mast cells live in intracellular space. So they're meant to look for threats. Like evolutionarily, that's what mast cells are meant to do. So when things are overly bendy, are they like, wow, this is a really messed up environment. Like it shouldn't bend this way. And they get constitutively activated? Or is it, there's a increased intestinal permeability because the collagen it just is not that, the tight junctions are loose, right? So you get a lot more gut permeability and leaky gut and more kind of immune activation. And that's how mast cell happens. Have you heard of TILT before?
Mm-mm.
Toxin-induced loss of tolerance.
Yes.
So it dates back to like the industrial times where we started a coal mine, and women that lived close to coal mines used to develop all these wacky symptoms. And of course, like older white guys like me would say, oh, it's hysteria, right? And the thought is like, maybe they were just living next to the coal mines and there's all these toxins that were pissing off their mast cells, that the mast cells are now recognizing these things that shouldn't really be around and causing them to be overly active. And, is mast cell a product of our environment, that all these, people with mast cell tend to smell chemicals and they get migraines and headaches. They have really sensitive smells. Like, so they walk by like the Hollister store at the mall and they almost have a seizure. And so like, is it that this environment that we bred that is very synthetic and full of chemicals and pesticides, people with mast cell feel so much better in Europe when they eat the food. And I mean, the regulation around food here, the pesticide use is crazy. And so I've had patients move to France because their mast cell is too bad here, right? And so there's something about the environment in conjunction with someone being bendy and hypermobile that makes this happen. I can't figure it out. But you're onto something as well. Like it's all theory, but they coexist all like at the same time.
Yeah. Which I also think because of the laxicity, maybe even in the bowel and like the rectum and things like that you see a lot more. In fact, you'll see more endometriosis, typically peritoneum, but bowel, rectum, bladder, things like that, even more than your ovaries, uterus, things like the reproductive organs are not nearly as involved as those other structures, those other organs are. And so I think that's interesting to think about as well, how much it plays a role in endometriosis. It's insane.
Man,
There's something still there.
it's really fascinating. As Zach, we have not heard about mast cell activation, obviously in med school and residency, and there's so much stuff coming out. I mean, you touched upon a variety of things that are associated with, just kind of throw up our hands and say, oh, well, we're not sure. Let's do some more tests. So, any kind of like research or view or different thoughts on these is important, because we still don't have an answer of like, well, inflammatory bowel disease, what's the cause of Crohn's? What's the cause of ulcerative colitis? We know what we see and we can treat it with anti-inflammatories, but we're not 100% like, I know how colon cancer starts. I know how rectal cancer starts, We think we know how endometriosis starts, but some of these things like you hit upon, absolutely true. There's something environmental that we're running into.
The reverse isn't the endometriosis, and like I am way outside my bounds here, but like isn't the endometriosis theory like the reverse menstruation?
That's old and it has not been proven.
Okay, because I was like, there are people that have that and then don't get endometriosis. Like, exactly. what's the difference? And I don't know. And is it a mass cell? I don't. It's for everybody.
Dr. David Redwine did a whole presentation, which you can find on the YouTube channel that I have. And it was prior to his passing. It was right before his passing, actually, where he goes through the genomic aspect of endometriosis and how he sees endometriosis, and has been proven to some extent, evolving in the body. It's very fascinating. And I encourage everyone to go back and listen to it, because I think it will spark a conversation. Why ACOG, why all these other associations aren't looking at what's being proven. Like if it were retrograde menstruation by now, I would think that they would probably have enough cameras to be able to prove it, but they cannot prove it. There's no actual evidence of it. But they have seen it in fetuses, which don't menstruate yet. They've seen it in very minute population of men don't menstruate. So I think that I think that all of these kind of go hand in hand. And Wendy Bingham out of Extra Pelvic Not Rare touched on the gestational yolk sac. And again, I'm out of my scope on this as well, but essentially they did this study where they noticed that when they broke off, like with the role of the yolk sac in gestation, when that broke off, what they were seeing is that a lot of these cells for these diseases were all together in this, whatever it is. I'm not doing this justice. I'm just saying that right now. But essentially, like they actually saw it in very young cellular phase of life. So I think it's an interesting thing to talk about. It's an interesting thing to consider, especially for those that have, for some reason, multiple diagnoses, right? Like it's not one. I don't know an endometriosis patient with one diagnosis, or I just don't. I have never met one person who can have excision surgery and be done. There's usually other things that they're dealing with. So I think there's something to it.
Mm-hmm. All right. There's so much to learn. So much to learn.
Yeah. Where can people find you guys to learn more? I know you're doing a lot of work, Zach, you have amazing content out on Instagram specifically. Where can people find you to learn more about mast cell, hypermobility, all the things that we've talked about today?
Thank you. That's very kind. So my Instagram is Dr. Zach Spiritos, and I have a clinic called Ever Better Medicine where we focus on complex GI conditions, POTS, mast cell activation. We see a lot of hypermobile folks as well. We are hiring more people and we're expanding our staff because unfortunately we don't have any clinic openings anytime soon. So we're excited to kind of expand our breadth and see people who hopefully, or who need some help.
Yeah, I love it. Vince, where can we find you?
Look up Vincent Obias in Washington, DC area, and endometriosis, and my website will pop up.
Thank you both so much for doing this kind of odd little black swan podcast interview where we don't normally get together. I appreciate you taking the time. I know you're both incredibly busy, but I just feel like this is going to help so many people maybe understand these little nuances of endometriosis, mast cell, stomach, all the things. So thank you both so much for sitting down with me.
Yeah, thanks for having me.
I appreciate it. Thank you very much.
Yeah, thank you. Until next time, everyone, continue advocating for you and for others.